All right, perfect. So we have the system set up here right now. In the background here right now is the tower with all the components, monitor, camera technology, and the irrigation system here right now. We have a specimen in front of us, and again, thanks to the amazing setup here by the Swedish Science Foundation. Thank you. We're going to be at 4.5. We already have a screw in place that is going to hold the entire system. So without further ado, so we're going to start out with an anterior X-ray here right now. Anthony is with us. Actually, Anthony's not. Anthony's over there. And we're going to get a little X-ray here right now. Perfect. So we'll use that as a starting point right on top of the disc here, a little bit lateral there. Skin knife here, skin knife. I'll open our incision. There we go. Okay, so skin incision, very similar to what Dr. Hartle teaches here, exactly, in fact, exactly the same. Always try to open the fascia a little bit. Okay, let me do this. Our first dilator, coming right onto bone. Okay.
Hey, Christoph, do you know if they have a navigated option for this too, like a navigated?
Again, really important for these procedures that each dilator reaches the target. Okay, so we'll get a. Do you have something to hold this with a little clamp or something? And you can see those little motions that you do to kind of clean up the bony edges. We'll get another shot.
Christoph, can you hear us?
Okay. So a little bit raw still there. So move down a little bit here, right onto the joint. I can feel the joint in there. Okay, next one, next dilator. And so now you can see we had the discussion in their camera. Would you mind just bringing the camera on this? So it's not entirely tubular. It's a tubular retractor and then has the little area on the side that allows for the camera to slide in. Okay. All right, so here's the tubular retractor. Again, same thing. Where's the camera? Is over there, right? No. There, the camera's here. Oh, up on the monitor. Here we go. So it is it is almost tubular on the side. In this corner here is the camera technology. So now we'll put it down there. Okay. I'll do this one more time. Or actually, might as well. And here we go. So there's a little holder, and you can squeeze it, put it on place. Okay. All right. Take one more shot there. X-ray. Give it a little bit raw still, so I can wind it down a little bit. Big overgrown facet joint. Shot there. Perfect. Okay, so now we can put our arm on there, and the arm, again, it can be either table mounted or it can be screw mounted.
Hey, Christoph, can you hear us?
Yep, of course.
Oh,
Yep.
great. Quick question. Do you know if they have a navigated option for this as well, or is it just you have to use fluoroscopy?
So for the dilation, everything I did right now, you can navigate the any system. I don't know if it's integrated with BrainLab yet.
The initial dilator.
Mm-hmm. Yeah, so the initial dilator you can use BrainLab for. And some of the instruments are also now getting, yeah, so the answer is yes. And how does this clip on? It's good on there. Okay, so click that on. Might have to do it. Okay. So let me fix that here right now. Let's see where we are before we get in there. One more shot. Okay, so we're right on there. Maybe a little bit more medial that we can see a smidge more here. Shot. Okay, so that should get us right there. Okay, so now we can take the dilators out. Now comes the cutter, so it's highly individualized. And so we'll put that down there. There's a little safety button that all the surgeons don't lose their fingers. It would totally cut a finger too, right? Yeah, it would cut a finger. Yeah, or a cigar. Depending what country you're in, probably. All right, so now the camera comes in, and the screen is, here we go. So here's the camera. Click it in here. So I'll pull it out a little bit. Here we go. I always like to see the walls a little bit of the camera, and now we can have some tools. So like a Bowie would be fantastic, a drill would be fantastic. Do you have a Bowie? Perfect. Okay, so now you see the tools here. Again, I'm pulling it out a smidge more. Oh, it's very short. All right, and so now, before I start here, I can actually start and flushing the system. So here's the famous flush here right now. Okay. Okay. Can I have the camera a little bit more superficial? Pull it out a little bit.
Just give a little more slack.
Yeah. Yeah, that's it. Yeah, perfect. So, yeah.
Bring it up a little bit more down.
Yeah. Okay. So now you can see the inside here right now, the soft tissue. We're right on the facet joint here right now. And you can see we talked about depth here right now, so clearly you can see how you enter the field. And now we can start our dissection here. So there's a Bowie here, and we're starting our work here right now. As you can imagine, the Bowie is certainly, you can see the smoke here right now, but again, the good thing is, once you are a little further, you can always easily flush the system. Good, and then that. Okay, so now you see every time I flush the system, it takes a second or two. You see this wonderful white screen. And then everything is nice and clear again. Okay, so now I'm resecting that paraspinal muscle here right now. Okay. Okay. Do you have a pituitary by chance? Thank you. Oops. Can we bring out the CM a smidge? Can we move, pull it out a smidge? Thank you. Okay. And you can see the value of being able to always kind of go back to a nice screen that is all nice and clear. There we go. Okay. Bring the camera out, switch pituitary. All right, so we're on the bony surface here right now. I don't want to pull out the tube here.
Hey, Christoph, is there a way to like increase or decrease magnification, or are you just stuck with whatever magnification's on?
Sorry, Paul, I couldn't hear you very well.
Oh, is there a way to increase or decrease the amount of magnification, or is it just one?
Yeah, so a couple of things you can do is you can come in further with the camera. And again, let me just clean out this area here right now. And I think that electronically, you can also change the orientation of the picture, which is really handy then afterwards. Okay, so now we have done our exposure, and you can see now really the quality of this camera technology here right now. So
Is it a little blurry to you, or?
it might be on the main screen. It actually is. I think that there's a little bit of stuff that gets lost in translation from the main screen to the broadcast here. We can maybe do one wiping thing here.
Hey, Christoph, I might have missed this earlier. It's Victor. So is this a HD or 4K resolution you're getting?
It's
here?
4K, so you can see here. So we wiped the camera, and I think it's quite a bit better now. So here you see beautifully the facet joint here. Here right now, here's the gap. Okay, and so I think we're good otherwise to start doing our bone work here. Okay, so here is, left side is rostral, here is medial, in there, here's caudal. Yeah, can we demagnify a little bit, or is it, can you?
Pushing it in and out is gonna.
Yeah, so here we go. So here, now, Paul, I don't know if that answers your question here right now. I was able to pull out the camera a little bit, and then you have a little bit more of a greater view. I always like to see a little bit of the edges of the retractor. That's just how Roger Hartle does it, and I think that's a really, really good way to think about it. Always kind of see the edge of your tube. So here we go. So now we can start the bone work. So we could go, in this case, can just go right down the facet joint. Okay, flush this. Bring it below. Okay, and again, the really nice thing about the system is like you can get a beautiful image in just with a push of pedal. Okay, so here we go. And then you have to push the right pedal, otherwise you get the right screen, even though we want to drill. Okay. All right, perfect. So here we see the facet joint, and then we can start. So now we can do a bone work. And so you can see the wonderful resolution as I'm drilling down here in the facet joint, starting to do a TLIF procedure. And again, I'm doing this trans facet here right now because the facet joint is quite overgrown.
So to someone who's used to microscopic visualization, this is two-dimensional, so trajectory is a little bit, you have to learn trajectory now and how you have certain depth, right, as you drill,
Yep.
correct? I mean, it looks like you're maybe going straight down, but it's a little hard to tell.
What's that?
Like your trajectory of the drill, medial lateral trajectory.
Yeah, so I'm pretty straight down. So my goal is I always like to see the traversing nerve root. So I'm in the facet. I'm drilling down the facet joint here right now. Again, and then taking on the SIP here.
Hey, Christoph, it's Roger Hartle. So can you just tell us again what's medial, lateral?
Yeah, of course.
Up and down, sorry.
So here is, this is medial, this is lateral, this is rostral, and this is caudal. And so I'm in the facet joint here right now, but we could also, start taking out that medial part and do a little bit of a hemilaminotomy. So you could also do that here, like going in like that.
So look for the ligament there and then go lateral towards the pars.
Yeah, exactly. So we could do a little bit of a laminotomy here, like here on top of the yellow ligament. Yeah. And you can see, the visualization is quite nice.
But you're basically removing the facet. You're not harvesting it now, right?
Yeah, I'm removing it right now. But yeah, again, I would harvest this piece here right now,
Yeah.
and then do the cut here, the straight cut around here.
See, we've done a lot of work with augmented reality now, and I'm just looking at this and I'm wondering, wouldn't it be nice if you could project your landmarks into that view? If you could see, you know, with the overlay, you know, where's the pedicle, where's the facet joint, just for orientation, you know,
Yep,
make it so nice.
Well, Roger, I think you
Next.
have a beautiful paper on that where you have the, where you have that sort of, you have the outlay of the augmented reality in spine, and I think that was really the only issue there. You were 15 years ahead of the game, but I think that's going to be the next step to outlay that. Why don't we get a quick X-ray? Just want to see where we are there, shot there. So again, right now I'm just trying to sort of see if I can take the part of the IAP down. Should be roughly at the disc space there. Okay, let's try that again, a little bit towards here. Perfect, so I'm right on the pedicle there right now, above the disc space here. And so come down, come out again. So go back here, so this is above the disc space. So we just have to take out this part here right now. So here, I could continue my laminotomy here in the middle. Gain the camera for a second. Okay. And again, you can see that beautiful image quality. So, and do that. Would you mind just, can we put the two pedals at different sides? So, okay, so. Okay. And here, we'll do the cross cut here. Some more bone work here, and then pituitary. I don't think it's loose yet. Let's just see here. Actually, it's already almost loose here. Yeah. So the anatomy comes nice into focus here right now. So you see the IAP coming down there. We're almost on yellow ligament here immediately. Do I have kerosene by chance? Perfect. Thank you. So the question before, can this be done? Can this be used for decompression surgery? Yes, absolutely. You can see here. I'm starting to see the yellow ligament there, and I can do my decompression along the yellow ligament there.
Dr. Hofstetter, it's Nima Allen from UCSF. When I started using Teligen first, I began by doing decompressions first. Do you think that's the appropriate learning curve, even though this is mainly for endoscopic TLIF?
I think it's always smart to start with decompressions first because there's just not as many steps and not as technically demanding often. And so yes, I think you can do discs, you can do lames, you can do all this stuff here. Again, as you can see, the nice visualization here. All right, so drill again. So I'm not entirely through here yet. Okay, so here, go there. And this is the drill pedal. There's also a little bit of a delay in the camera here, so in the broadcast, because I'm looking at the same image that you guys are looking at, and there's a slight delay there, so it makes it a little interesting. And there we go, so now it should be down there in a second. Okay. I can just flush it. You don't have to irrigate anymore, it's all automatic. Or the suction is clean, clean that suction. Perfect, thank you. All right. Do you have a little, do you have another suction tip
Actually, here, give me, yeah.
for the meantime?
Yeah.
Yeah, let's just change it. Perfect. Okay. Okay, so as we're doing our hemilaminotomy here right now, again, I am almost on the L ligament here in the midline. Okay.
Christoph, this is Mohammed from Duke. Very beautiful things that you're showing. Can you talk a little bit about the advantages versus, this is an air-based system versus endoscopy with a water-based system, and why you like one over the other?
I think the big advantage here is that you have you can use standardized instruments, right? And you have really your bigger field of view. So for example, here right now, what I'm doing here right now, I couldn't do with the full endoscopic system, right? You can see that I'm doing my decompression here at the same time that I'm also doing my work for the TLIF. So right, this is really a decompression and exposure. So again, right now I'm working on the infraarticular process, doing our hemilaminotomy. Here is going to be roughly my pedicle. Here's the cross cut here right now. And so that would be very difficult to do with a water-based system because they're just not as big enough. So one thing is where, really we, and again here the IEP is coming out, pituitary please. So one issue that we struggle with the full endoscopic systems is patients that need both, and you can see how I can take this gigantic piece of facet joint out here right now as my bone graft, and holy moly, look at that. Oh yeah.
You couldn't take that out of the
Did you
endoscope.
guys see that? That was not only the camera.
That piece wouldn't come out of the endoscope.
Yeah, the whole thing came out here right now. So now we're looking at the SAP there right now, the exposed SAP, the joint here. And I can take the drill here and continue to work here. Go. Yeah, so back to the question is, where's the advantage? I think the advantage is that you can actually do both the decompression and the approach at the same time. So it gives you a bigger window. And I think the future is going to show if that's going to be biportal or systems like this that allow us to do that. So certainly an interesting approach. Okay, Harrison, please. Okay, so get in there. Okay. And so right now we're just doing our decompression as well as our exposure. Do we have bigger kerrison? This kerrison like a 1 millimeter kerrison. I don't know. No, thanks for making it hard. Perfect. This is also not a kerrison. They're intentionally giving me small instruments here, so otherwise it looks too good. I understand. Okay, so we're cleaning up the field. A little bit of joint here. And everything else is in, exactly as you would like to do it. So here in the middle we have yellow ligament already a little exposed here. SAP is gone. SAP is still there. And here we get in the joint. You can see here. I can go lateral here. So here's a cut from the infraarticular process that we did before. Here's yellow ligament here. Here's the joint space. And here I'm just making my cut. I cut the SAP out right there. And here's where I would start then the disc work. Okay, and we can get a quick x-ray there. It'd be nice to show that. 1 second, let me know before you shoot. Okay, so should be right on top of the pedicle here. Let's get a quick x-ray. Actually, do have a smaller marker. This might look not very good. Actually, here. 1 second. Come towards, push it in a bit, yeah. Actually, go south. Perfect, so you see I'm right on the disc space, right where I want to be. Come out again, and so pull out. So here is, I'm right on top of the pedicle here right now, as you can start seeing the Campion's triangle, the content of the Campion's triangle. And we are in excellent shape.
Hey, Christoph, it's
Yeah.
Paul. Can you just demonstrate kind of the look around the corner there? Like,
Yeah. Oh, yeah,
let's say you're trying to clean up
Absolutely.
that lateral SAP. That would be a good thing to show.
Perfect, thank you. That was a really good suggestion. Take one more bike here right now so we can look around. Okay, so the nice advantage here is that you can take the camera in here now, push it forward, and rotate the whole thing. So now you can look north. You don't even see that area here right now. So you see my cut here right now. You're looking rostrally here right now. So this is the cut in vertical process, the first cut that I made. Then we remove the piece. Then we're looking medially here right now. We're looking downwards onto the joint here, joint space. And then we're looking straight medial lateral. And then we can also, some surgeons actually like to do this view here where you actually look outwards. So you can actually now look towards the remainder of the SAP right now. And so this would be, again, my view, my anatomical view onto the side here right now. And how many degrees is it off axis? I think it's 15, right?
20 to 22 degrees on.
22 degrees. And so here's a little bit of SAP left. I can remove that. And then I'm right in the Campion's triangle down there, and I could start my disc work here right now. So again, the decompression is not entirely done yet, but you get the idea. Okay, so I'm just doing a little bit more of the joint here. And it's beautiful visualization here down there, as you can see here. And again, the nice demonstrating this again here. Let me flush one more time here. And again, it takes a second of bright white. It's really good for the winter months when you need some light, for your mood, cheer you up. And then we can look around down there. Again, look up north. And we're looking straight down under the Campion's triangle. Come here, Harrison. I can lift up the yellow ligament a little bit here. Maybe you see the traversing nerve root here. That's so smooth. Okay, taking a cut underneath it. And again, the nice advantage here is really what makes me jealous is you can use your normal surgical tools. And so, see, let's say you want to take that bite and you don't know if you're really safe, then you can actually turn the camera. You see that? You can turn the camera seamlessly and then engage here and make sure you really don't grab anything. There we go, take that bite here. Totally safe because you see exactly what you're doing. And now we can go back. Okay, perfect. There we go, starting back. How much more time do we have? I think we're kind of getting to the
5 minutes.
5 minutes.
So
Okay, so I can take a minute more.
if you have enough room to show a discectomy.
What's that?
Do you think you have enough exposure to do a discectomy or at least show it?
I think we're almost there, yep. Yes, we can definitely. I'm just taking a little bit more of the IAP out there laterally. Okay. Do you have a pen filled or something? Thank you. Oh, it's not. Do you have a long pencil that is like? All right. So here, I'm just going to mobilize the traversing nerve root here. There we go. Okay. So here's the beginning of the neural elements here. I think there's a little, yeah, so that's the traversing nerve root. You guys see that here immediately? Okay. And so I can actually put a little retractor in there. Again, the nice thing is you can do bimanual surgery here. You can lock that in there and then go a little bit more lateral. Okay. And the kerosene, please. So now we have a traversing nerve root nicely exposed. And again, of course, you can do more decompression there too. And then we take a little bit more of the joint there laterally, so we expose. Okay. Okay, I'll take the drill for one more second. And what do you have for discectomy? What tools do I have for discectomy? What tools do we have for the discectomy? Yeah, shaver is perfect. So we can maybe put a shaver in there.
Christoph, we mentioned this before, but I mean, our visualization is probably not as crisp as yours. I think it's just because it's a secondary camera.
Yeah,
'Cause
it's
a little
actually,
bit
I'm looking at your same visualization too. Really, I would invite anybody to come back here. I mean, again, Seattle Science is doing an amazing job to kind of get this over so streamlined, which is really amazing. But I'm struggling here a little bit too. There's a little bit of a delay. So the instrument is coming in right now, and it's just it's 1 second delay. So it's kind of definitely a little challenging here right now. But
Yeah, I just mentioned so that audience understands that the visual quality is better than what's being shown.
yeah, there's definitely a little bit of a delay here right now, but I think it's good enough to kind of get the idea. And so here you can see the bone work. So here's a little bit of the SAP left that I'm drilling down here. Okay. Perfect. And then we have a little retractor that we can put in there, right? This guy, yep. And so that's a really neat thing here that you can actually see how the muscle is creeping in on the side. So you can actually put a little retractor right on top of that. Muscle creeping in on the side and retracted. Do you have a smaller one too? Yeah, yeah. So, or you can actually have your assistant pull this out of the way here right now. And so down there, we're getting more and more ready for our discectomy part. Okay, take the kerosene. Okay. So there we go. Okay, so you can see down there, we're preparing Camden's triangle. I'm right now in the frame and already here on top of the nerve root. Game, please. Okay, and so I can change my camera a little bit here. But actually looking towards me, which makes it a little bit easier sometimes. Can we change the camera? And so that's a neat system here right now. Is that actually I'm starting to look medial, and I can change that. And so now I don't have to think about it. And everything is again back anatomical. With the upper screen is medial, and the instrument is coming in, and I can just take those couple more bites. And then do we have a little shaver? You can just demonstrate how and then flip the camera around again. So there we go. Change again. Perfect. So I have a little bit of muscle hanging in there. Do you have to just demonstrate where we are? So if you have, here is the Cambian's triangle exposed, and I'm right on the disc space here. Let's get an AP and lateral X-ray there. Okay. Can you come south a little bit? Perfect. So I'm right there. And then let's get lateral. So I've exposed my traversing nerve root nicely. I'm right in medial to it. Everything is visualized. And now before I advance it to the disc space, I'm just going to get a little bit lateral X-ray. And again, that's a neat idea about this technology, is that I was able to see the neural elements, visualize it all the way throughout. Now I'm in the Cambian's triangle here, and I'm ready to go into the disc space. Go. Perfect. It's a very collapsed space, so mallet, please. Your mallet, I'll just bring it there. Great. So just for the demonstration purposes, just go ahead and bring it in there. X-ray. Go, shot. So I see that I'm nicely in the disc space here. I can hear how I'm mobilizing the disc. Pituitary. Okay. And we can go back here right now, and you can see the nice opening of the disc space in the Cambian's triangle here right now. And now I can start my discectomy, and then obviously you can do anything you want here right now, bring in the cage or any other technology that you want to bring in, which is, I think, a beauty of the system, that it's open and you can use anything you want. Okay. So I'm in the disc space. X-ray. As you can see, doing my discectomy here right now. Full visualization. I can look around here right now like we discussed before. Whatever angle gives you the best visualization. Again, with a little bit of muscle hanging on the side. Should be nice to get rid of, and you can see here I'm down there in the disc space, lateral to the neural elements that are medial. And I can flush it one more time here. And you can see that we didn't do a complete decompression. We just did a hemilaminotomy and saw the traversing nerve roots. We didn't do the entire thing, but you can see the power of the system, as it was very, very fast to get in there, very fast to do the facetectomy, get into disc space. So, and again, it helps to standardize because everything is very nicely visualized. So I think really worked out nice. I want to thank the team here, guys, for setting everything up. Julie, best X-rays ever. Next time we'll do color, okay? Perfect. Any questions in the audience?
No, great demonstration, Christoph. I think we definitely saw the advantages of this technology, particularly I think turning the camera and getting a wider field of view in certain angles is probably one of the biggest benefits.
Yeah, and I think this is just something that you can't do with the microscope, right? I mean, looking up here, you can actually see, you could look into the foramen up there, right? So you can see the fat down there, you can see the disc opening, but above it, you can actually see the yellow ligament and the bone there. So you could really go up there north, look at the exiting nerve root. We definitely see the traversing, we see the traversing nerve root right medially here, right underneath the tissue, traversing nerve root here. Again, nice and safe. Yeah, everything looks fantastic. So thanks, guys.
Yeah, thanks, Christoph.
Yep. Thank you.